Welcome to the Every Brain Matters podcast. It's just pot. What's the problem?
Hello and welcome to the Every Brain Matters podcast. I'm Heidi Anderson Swan, your guest host today. Please welcome our special panel today. We have, of course, Aubrey Adams, our founder of Every Brain Matters, Bryn Spejcher, and she will introduce our special guest, Dr. Daniel Buffington.
Thank you for having me. My name is Bryn Spejcher, and I am an audiologist, and I am here with Every Brain Matters to serve my probationary terms, which includes 100 hours of community service, educating the public about the harms of THC. Back in May of 2018, I experienced cannabis-induced psychosis, and it led to a tragic outcome to the Amelia family. I'm just so sorry for what happened that night and for my actions and the unthinkable loss that you guys will have to endure for the rest of your lives. I will truly never understand the gravity of your grief. Dr. Daniel Buffington is a clinical pharmacologist and toxicologist, and he's also the president and CEO of Pharmacology Services and an associate professor at University of South Florida Colleges of Pharmacy. And the reason I know him is that he was a professional expert that testified at my trial for the defense to talk about the science behind cannabis-induced psychosis and other important information that you'll hear today.
All right, Dr. Buffington, I was at the trial every day, and I will never forget the presentation that you gave. It was extraordinary. You were the defense expert. Could you please share with us some of the things that you talked about?
Sure. So this was a very unique trial, and it's something that is unfortunately becoming more and more common in society today. I think the core and the foundation of the case required the court to understand, and I'll say that probably most individuals don't, and many healthcare professionals don't either, is to understand the impact of the pharmacology and the changes in the pharmacology of marijuana as a plant, as a substance that people use recreationally, medicinally, and its potential for causing severe psychiatric reactions. So someone can sit down and have no anticipation of having some type of an extreme effect, but in fact have a very bizarre and exaggerated psychiatric effect. So in this, the presentation that I provided in the court was to help to give a history of the changes that have occurred in marijuana as a plant over the years. And with that, the history of marijuana is something that dates back hundreds and thousands of years. It's a plant that's been known and established for many years. There's three specific species: Cannabis indica, Cannabis sativa, and Cannabis ruderalis. And these are the most common strains. So when you think of a plant, that you could say a banana plant or tree, and there's different strains or variations of that. Within marijuana as a plant, that describes the plant. It is in the cannabinoid family. So when people use the word cannabis, it means one of the known and established plants. But when we look back through history, the potency, meaning there's probably over 450, over 500 chemicals that we've established in the marijuana plant, in cannabis plants. The most significant two that we have the most medical understanding over are THC, or tetrahydrocannabinol, and that is the agent that produces the most psychoactive effect. And when I say that term, it's not necessarily bad. It could be that the symptom of relaxation. It could be the symptom of decreasing anxiety. It can be the symptom, the effect of producing increased appetite when we use that for those conditions with HIV and with other types of muscle wasting conditions. The other main product is CBD, and we've probably all seen an abundance of these advertisements and products find their way into the market. The reason CBD, cannabidiol, is more popular and prevalent is that CBD is not associated with as much psychoactive effect, and it has other effects on the intestinal tract system, on reducing seizure disorders. But when we look back in history, THC, the primary psychoactive agent, used to be 2 to 4, 5%. We watched over the years that grew to 6 to 10 to 12% on average. So if we just even look back to 2014, that at that window, we were seeing people who grew, people who cultivated. So just like we look at agricultural science for food products, corn and other types of citrus, and that there's been advances and modifications that take place over time that enhance a particular species and its effects, or strains of plants. The same thing happened to marijuana along the way. So by 1985, so a lot of people think we didn't have medical marijuana until just recently. We've had multiple prescription medications that were THC, the active ingredient, isolated and available in pure form for medical use. But the problem that we saw is there was this increasing attempt to cultivate the same species, but that were producing or contained higher amounts in the plant naturally of THC. So we watched it grow from 2% to 12%. Between 2014 and 2018, we started seeing those strains be able to produce upwards of 20%, which was a substantial increase over 20 and 30 years ago, over the years that most people societally thought they understood what marijuana was. By 2018, we started seeing those numbers grow even more. And now it's not uncommon to find strains that include 20 to 35%. And now we're seeing upwards of 70 to in the 90s. Recently, I identified a product that was commercially posted online that was touting 85+% THC in the same weight. So I think it's important that people understand that what's available today, and you don't know when you walk up to with great certainty from state to state what you're getting medically, maybe a little more variation and control, but what you're getting outside in the non-medical marijuana arena. And people think that because there's laws and regulations for medical, that the other goes away. In fact, the non-commercial versions just continue to modify themselves to try to be bigger and stronger than what you can get to keep attracting people to that. But that's the equivalent of taking if you just convert it to a medication use, a prescription medication use, that's like a product that might be 5 milligrams of a drug years ago, and now it's 50 to 100 milligrams, just that higher amount of potency and drug that can be delivered. So I mentioned that there's been a lot of research. I think this slide helps to put it into perspective, is that between 85 and 2005, you can just see the amount of interest, the amount of resources, the amount of clinical research activity that went into that substantial increase in THC potency. So you still may find something that's a lower potency, but without knowing any different, if someone shares marijuana with you, you have no idea whether or not what's being shared could at the same time be extremely high potency. And I think it's important to understand how it works in the body. We have all different kinds of receptors that control inflammation, that control mood, that control your blood pressure, that control all body systems. The cannabis plants and the chemicals in the cannabis plants work on two primary specialty receptors called CB1 and CB2, cannabinoid 1 and cannabinoid 2. With that, the THC at lower doses works predominantly at CB1 in the brain, and cannabidiol can work on in the brain for seizures, but also in other parts of the body. And with that, at lower doses, you would typically see the things you associate: euphoria, relaxation, reduced stress. Some people will say a sense of increased creativity, changes in sensory or sexual awareness. And then with CBD, you get some of those relaxed anxiety, but you also get some other effects on seizure thresholds, what the parts of the brain that control seizure activity. The problem, though, is the higher potency is now an entirely different set of psychiatric symptoms. We get impaired cognition, loss of memory, paranoia, panic attacks, psychoses, and an altered state of consciousness. So again, you think you're going to use something that's probably of a lower potency, possibly get exposed to something that's a higher potency, and those general effects, you're going to experience something much more substantial. Now, I'm not saying that every person who smokes a higher potency product is going to have the same effect. And one of the reasons is because if you are if you are a regular individual who uses cannabis and you're using increasing potency levels, your body and those cannabinoid receptors become more acclimated. They get used to it being there. The other problem is that while we associate, and I don't think this is really well understood yet, is most people, including regulators and various state regulations, think that CBD has no psychoactive effects. The problem is in the higher potency products, the CBD can also have it crosses the threshold and also causes more substantial effects as well. So it's just the number of emergency room visits and consultations that are happening related to people who have just taken a product and were not used to taking it are having substantial reactions. So the number of emergency room interventions is increasing substantially. We talked about this is that it's one thing to increase the potency in the plant, but think about how much THC is in that raw plant on the left in the illustration. But just like pharmaceutical sciences, we can take a lot of that plant, distill it down, and make something that's a higher concentration, meaning per weight, it only takes a tiny amount of the weight to have higher amounts of THC in it. And these are called, it's called dabbing, and it could be in the form of waxes or other types of more solid forms. So it's one thing to look at the plant, it's another to say that you might be exposed to a concentrate. If that wasn't enough to confuse you, what we're seeing now is people blending concentrates onto marijuana leaves to try to increase the effect as well. If there's a takeaway from this entire part of the presentation, it's that you just can't tell. Your eye can't discern what you're going to be exposed to at the moment you say, okay, I'll try that. So it's the same active ingredient, but substantially increasing amounts. Again, it could be the effect of, matter of fact, let me share this with you as well, is one of the common forms or mechanisms to use marijuana is, and it's been around for forever, called a bong. And what's important there is you see on the right-hand side is he's holding in his hand a chamber, and that's where you put or a bowl, and that's where you put the marijuana plant, the leaves in. And then you pack that, you put it back onto that little stem that's sticking out. And in the marijuana bong, at the bottom, it's filled with water. The person will inhale, so you hold a lighter up to that, and will pull flame into the plant material, the organic material. And at that point, creating smoke that's coming back through the water and up into the chamber. So if you can see that chamber, you could see smoke. It is very possible to not inhale while you're doing that, and you're putting that in the chamber, you're stacking that. So you stack that dose. The problem is that if one person is making for another person, you can burn, rip, or bring in one dose into the chamber, the large, tall chamber. You can then burn more. You can then burn more. You can then burn more. If you think of it in the equivalent of medications, I used this analogy previously. If I give you a pain medication that's 5 milligrams in a tablet, and I say to you, did that do anything? Do you feel that? You might say, no, not really yet. And I give you a second. It's not that you're getting a second hit. You can stack the chamber of the bong, the tall portion you see on the right, with multiple. You can get 5 to 10 hits in there. That would be the equivalent of turning around and then saying, here, take 10 tablets. See what that does. I think as an analogy, people can understand. But the difference is if you only put one, if you only draw one hit into that chamber, you can still see through it. You see the smoke, but I could see his shirt through that. You could probably see his hands in the other side. As you bring more in, it becomes more solid. It becomes more opaque. So in that sense, that's what's referred to as milking. In other words, you're bringing so much smoke in that it's become solid, and it's an indication that someone has brought in multiple doses. So if we go back and think, wait a minute, a naive person who's not used to high potency marijuana, high potency THC, then through a delivery system like a bong, if you take a tablet or a gummy, it's got to be absorbed through your intestinal tract and find its way into your bloodstream to then find its way to those CB receptors. The difference is your lungs are an amazingly efficient absorption vehicle. So when you inhale through, say, a nebulizer, you're getting a large amount of a medication. We do this frequently for asthma patients, COPD patients, pulmonary fibrosis patients. It's a way to get in a lot of medication at once. When you inhale or draw on a individual joint, there's only so much air can draw through that, and only so much smoke you can inhale with a standard, we'll use the term puff. That is substantially different than a bong, where you might get multiple doses at one time and delivered very rapidly. These are all risk factors for a very bad outcome. I'll use the term a perfect storm. So these are things that become important to understand. So if we look back to Bryn's case, it was a unanimous decision by all the medical experts on both sides, the state and the defense, that what we saw in Bryn's case was, without any question, a drug-induced psychosis. And we can narrow that and actually say cannabis-induced psychosis. And these are some of the key factors why. One is Bryn was, for all intents and purposes, a naive user, someone who had only experienced or had partaken only a few times in her entire life. Two is that based on Chad's purchasing patterns, it was evident that he was purchasing high potency marijuana. And it was from purchase receipts. In fact, the manufacturer, the site that he was purchasing from, even they posted on their site not to give this type of marijuana to a naive user because of the risk of substantial effects and adverse reactions. It was delivered through a bong. So naive user, high potency product, rapid administration. To her recollection from before the first hit, she could see through the bong, could see smoke in the bong chamber. But on the second that he had prepared and gave to her, is that was solid white and could not see through that. So that's indicative of stacking. So manipulating the amount someone's going to get. The other issue is that Chad had an understanding of what that could do, not that Bryn understood. Chad had done this, prepared and given the same type of marijuana to a roommate who also had a severe psychiatric reaction in just the 2 or 3 months prior to this event. And that the last issue was that the lab validation confirmed that the only psychoactive substance for Bryn was THC. So when you bring all these together, it was that perfect storm, but also every box was checked to provide a sense of confidence, medical decision confidence, that it was a drug-induced and cannabis-induced psychosis.
Thank you so much. Yeah, that was an excellent presentation, Dr. Buffington. Can I ask you a question? One of the terms that was brought up during the trial was a term called shotgunning. Is that something that you can explain to us?
So shotgunning is typically where one person takes the dose and then they turn around and give it to the next person, but like oral. So the one person brings it in, inhales it deeply, but then they blow that into the next person for them to inhale, mouth to mouth. In this case, it was more Chad was preparing the device and inquiring after the first dose or the first hit, did that make you high? Do you feel impaired? Asking, knowing that it was high potency, but asking what she felt. And when she stated that it didn't, he turned around and made another preparation. Yes.
I will say that he didn't ask me if I was feeling anything. He once, at some point, he said that, oh man, I'm feeling really high. And I was like, oh, no, I don't. Like, I don't feel anything. And he was like shocked by it. So it wasn't a matter of, are you feeling are you feeling high? It was just more like, he just made a statement and I said, oh yeah, no, I don't feel high and I never really do after just, smoking with my friends in the past. So that's when he was like, oh, well, we'll make this next one really intense. And to me, I'm like, I don't even know what that means. Was he kidding? And then everyone knows what happens next. But so, I guess specifically, he didn't ask me if I was feeling high, but it did come across that message that he, later found out I was not feeling high after the first hit I had with him.
What's uncertain about that moment is what was the motivation. I liken this to having thought about this case so many times is there's times you might see reels or video post of someone who's had, say, a tooth extraction or some basic dental procedure, and they're coming out of anesthesia. And I think people think that's funny when the person's at risk of harm in those moments. So I ponder what Chad's motivation was when he had done this to someone before and knew what was a potential to tee her up to have, let's just say, an extreme reaction, even if it's just intoxication. I don't know what the motivation was or what he thought would happen, but what's apparent from her recollection is the first dose or hit and the second were substantially different. And in fact, from her testimony is it was just shortly after the second that she clinically and cognitively started to decline between the coughing and the severe respiratory reaction, but also beginning to experience psychiatric symptoms as well.
Dr. Buffington, can you explain the difference between cannabis intoxication and cannabis psychosis?
Sure. So intoxication just means that something about you is altered or impaired. So if you remember back to the slide about the CB1 and CB2 receptors and low potency and high, intoxication would be maybe even that sense of you go from feeling tense and anxious to relaxed. So if I use the analogy with alcohol, if you drink a glass of wine, you might say, well, I feel a little more relaxed. You might be more talkative. You might be more social. It's still alcohol. But if I say now you've drank 4 glasses or possibly 8, we're already accustomed to understanding that with alcohol, you can see cognitive decline and physical decline. It's no different with THC. So this isn't a debate of treat THC the same as alcohol socially. That's a decision every state's got to make as to how to do that. But alcohol comes in different potency and concentrations. You can drink different quantities, but what we see is when ethanol, the active chemical in alcohol, is in the brain, is we see that someone's cognitive status, their ability to make good decisions and judgment, their reaction times, their stability, their walking, there's cognitive and motor changes that begin to decline, and it's a continuum. So if I give somebody a glass of wine, or let's just say a beer, that's probably going to be 3 to 5, 6% of alcohol in that liquid, in the glass, same size glass. If I give you vodka or bourbon, now we're talking about 30 to 60% alcohol in the same quantity. It's one drink. But if I give you grain alcohol, we're now approaching 100%. So one drink depends on what you drank. It's still alcohol. So I think the same thing we see here is that a small amount of THC is going to have some relaxing, some stress reduction effects in the brain. And it can have other effects on gastrointestinal symptoms and arthritis and other things too. The studies are showing that it does have medical and medicinal purposes, but we have to respect that as the concentration consumed goes up, so too becomes the ability for impairment or intoxication. Psychoses, what you wanted to compare to, is an extreme sense of a psychiatric state. So anxiety and paranoia are stress and fear. You're interpreting your surroundings as causing you stress, and you're finding things that you're afraid of, possibly more than you should be. So profound paranoia can be debilitating. Many people end up in the emergency room in extreme states of paranoia to where they can't move, they can't communicate with other people. So even in those, there's elevating levels of intensity of the symptom. Psychoses is what I would call one of the most extreme psychiatric reactions, because the individual on the continuum up to psychosis is going to be hallucinations. Hallucination is a misinterpretation of your senses and your surroundings. Okay, that's a very scary place to be, when the people you're around, the place you're in, the things that you know could turn into manifestations of other things. In other words, you're no longer processing your surroundings accurately. Very scary. Psychosis goes beyond that, and you are no longer in touch with your reality. You may be standing, you may be talking, you may be communicating with someone, and it's as though you're not in the same room. So again, it's sad, it's unfortunate, but there are more people who are naive or have an underlying psychiatric condition to start with, who then get exposed to high potency without knowing, high potency marijuana, who are then exposed in a rapid administration. And what we understand that's happening is the brain uses a variety of chemicals. We call them neurotransmitters. So these are things like GABA and dopamine and serotonin and things you've probably all heard discussed. The problem is with the high potency marijuana, you get an exaggerated, I'll use the term dumping effect, where there's cells in your brain that have these chemicals. We depend on them. We naturally produce them. The problem in this situation is it's as though the floodgates open and everything comes out at once. The brain isn't ready for that. That's part of this phenomenon, is that the scenario that I described, a naive individual, high potency, rapid administration, has a exaggerated dumping effect. Now you have so much dopa and glutamate that are working at the same time that you have a psychotic reaction and you lose touch with your surroundings and reality. You're awake. So many people may think, well, you mean they passed out? No, you don't have to pass out. You can be physically standing, moving, doing things. It's the brain that's disengaged. Psychosis is a detachment of reality in that moment.
Thank you for explaining that. Through my research, I learned about, alcohol being a water soluble drug compared to the cannabinoids or the THC and CBD and the cannabis plant are fat soluble. I'm curious, as the potency of alcohol goes up, is there just the same kind of risk to go into psychosis with alcohol that there is with THC in the cannabis plant?
It absolutely does happen. So in severe chronic alcoholics, moments of psychosis and paranoia, in fact, it's what drives many people from chronic use and abuse to losing jobs, breaking down relationships and communications and ending up in rehab, is that sense of losing touch with reality.
And can you get that through a one-time use, like with alcohol, like Bryn did with the kind of the one-time use with the high concentrated THC?
So sadly, not only can you get it, you can also get death. There are many examples. We've had some in the last 2 years with college students who have done extreme binge drinking or challenges or fraternity exercises and things where people have become alcohol toxic and died in the moment.
In the one slide you showed about the parameters that all set up Bryn to be at the high risk of going into a cannabis-induced psychosis at night, you talked about the bong being a rapid delivery system that provided that THC very rapidly to her brain through the lungs. Would you put vapes in that category too as a rapid delivery system?
100%. But remember because it's the same tissue, you're exposing chemicals to the lung tissue, or what we refer to as the mucous membranes, the lining of the lungs. The difference with that is what is in the vape that's being ingested or inhaled. So unfortunately, we're seeing the same thing now. So people are saying, well, I can buy vapes and the devices all over the place, and I can use this now without being chastised or in trouble because they're socially acceptable. It all comes back to what's in the vape. So you remember me talking about the dabs and the concentrates? We're starting to see now that you can buy cartridges for the vapes, not commercially at the store, but black market, where people are putting high concentrate into the vape cartridges as well. So the lungs are the vehicle. It just depends what you're putting and the quantity you're putting in. So if it's high concentration, if it's high potency, it's also going to be rapidly crossed into the blood and available to the brain.
That's so interesting. We learned from another doctor, we're in touch with Dr. Libby Stout, that somebody smoking a joint, the smoke, they're really inhaling about 25% of the THC, and the rest is kind of dissipating in the environment. And I noticed that with bongs too. You're taking in the rapid THC smoke, but some of it might be dissipated in the environment. When I'm observing, especially these young kids vaping marijuana, it doesn't seem like anything dissipates into the environment. It's like all going into their lungs. And I don't know if that's just a biased view I have. Do you have any opinion about that? Or do you think they're getting more of the THC with the vapes?
So I think the best comparison is back to the joint. And in a joint, there's a limited amount of air that can pass through that line space, past those marijuana leaves, based on the strength of your inhale. But when you look at the concentrates in the vapes devices, when you look at the concentrates in the bongs, you're already getting a substantial amount more just in that same inhale.
Can I ask a question about it? And Bryn, I'd really like for you to weigh in on this. I read that some bong users, when they were talking about how to prepare their hit, then they describe, okay, and then after you've stacked your hits, and then you put your mouth to it, and whoosh, it all comes up. So does the smoke power up through the bong into the user, as opposed to, say, if you have a joint, you're taking a pull from it, or a cigarette even, you take a pull from it. Can you describe?
So I'll take a quick response to it, and that is the amount of pressure you apply to draw. When it's the bong, there is just a higher amount of the drug that's coming in that same inhalation. And that's the primary difference. Go ahead, Bryn.
I'm not sure. I mean, what you want me to say? Are you trying to ask, like, is it natural for the smoke to shoot out of the bong so quickly, whether there's a mouth on it or not? Is that what you're trying to get across?
Yeah, yeah. Was there so much smoke in there that there was pressure that it came out at you, not just that you were breathing it in?
I mean, remember, like, all of this was happening in seconds. So, I don't remember, like, if I felt pressure in terms of the smoke pressure. And again, I also don't know how much I've also inhaled either. So I think it's kind of an unknown question as to whether or not how much smoke was actually in my system. But I think because I did inhale some of that smoke, it just led to obviously the effects immediately. I don't know if there was like pressure from the smoke automatically going into the lungs.
Yeah, you wouldn't expect there to be a change in pressure. There's just more drug in the same space.
Correct.
Okay. One of the things that I've said to people about this is, if somebody hands you a strong drink and they say, "Here you go, try this," it's in the user's more in the user's control to take a tiny little sip and put the drink down and be like, "Okay, thank you," and you have more control. With the bong and with the hit that you inhaled, I got a sense that there was less control. Can you comment?
From me?
Yeah.
Yeah, I mean, yeah, I guess that's probably a good point where, yeah, do you take a sip out of how do you take a sip out of a bong? I don't know. Um, but when somebody is pressuring you into, hurrying up to smoke it, I don't know. Is there control in inhaling something like that, especially just smoke, when you don't have like a physical feeling like a sip of alcohol versus chugging an alcohol drink? Because you're talking just one inhale. Like I don't know. I don't know what the best way to answer this, because it's just
I think you did it right. Is the duration of what you're doing in that moment that is like a sip. It was a short window that's drawing what's in that chamber up into your mouth and into your lungs. So it's not like you do a partial. If you did a partial, just a short, there's no difference in taste. So it's not like you're gauging, should I keep going? Is this maybe too strong? It's just smoke, and it's inhaled in seconds. Which is probably one of the biggest take-home points of this, is you think it's just one inhalation, and it could be many doses compacted into the same amount of smoke.
It's interesting because you said that, how she inhaled was sort of like a sip. And so imagine she didn't get that much smoke then in the end, but it was still so strong. It was strong enough to have the reaction that it did.
It was what was in that chamber that was the issue, because it was so much THC in the same amount of space that you could bring in to your body quickly and into an area of tissue that is incredibly efficient at absorbing.
What is the percentage that is considered high concentrated marijuana? Is it products over 15% or 10% or?
So it's a very nebulous question, meaning this has been a moving target over years. So if you ask that several years ago, anything 10 and 15% was considered major. If you now said in 2015, you could say, well, 25 and 50%. And in fact, if you look at many state regulations on what can be purchased under the presumption of medical marijuana, which is less of a prescription and more of a hall pass, is the way I refer to it. A prescription from a healthcare professional says you can use X amount of milligrams in this formulation X number of times a day, and that's a therapy or a treatment. That's not the way medical marijuana works. It's you can go into the store and purchase this, and you can use it on a daily basis. So it's very different from that perspective. But coming back to your point, is if you look at regulations, many states are trying to regulate the concentrations of what those medical marijuana outlets or dispensaries have available to the public, and then be, again, probably 30% and under. And when you start to see facilities where in a recreational state where there's even less boundaries, you're starting to see those percentages go up. So what is a high percentage? Well, for a naive user, anything's at risk. For a naive user, 15% and higher is going to produce a significant effect. 50% and higher would just be absolutely, please don't ever even do this, because you don't know what you're going to get in terms of magnitude or intensity.
I have to make a comment here, and that is that when I was young and I was a naive user, and it was back in the late 70s, early 80s, so somewhere between 1 to maximum 5% THC, I had a couple of hits and I had psychosis. And that's, I mean, that's low potency marijuana. So my genetics are extremely sensitive to THC. So any amount is too much.
So I can share with you that the volume of times that I'm teaching this topic or doing research with this topic, there is rarely a time that when could be in an exam room with a patient and the topic comes up. It could be in a classroom and there's students there, graduate and professional students, colleagues, academic professionals. It could be after the camera goes off on an interview and somebody says, "Can I just share with you?" I can barely ever make a presentation that someone doesn't follow with a personal experience or a close friend's experience. And I mean to the level of going to emergency rooms, catatonic states, which is where people feel frozen, debilitating paranoia. There's a lot of people have bad reactions. Are we saying to this level? No. And thank goodness they're not extremely common. But the worry we have in healthcare and in law enforcement is this is increasing, directly corresponding to the increasing potency that's available. And I think corresponding also with a social sense of acceptance and thinking, well, I don't need to understand it medically or chemically or pharmacology, but it's recreational now and it's okay, so I'm going to try it too. That is a terrible recipe for a potential bad outcome.
Yeah.
And it's one of the things that has made me relate to Bryn Spejcher's case so much, Bryn, is because I just imagine me with my sensitivity in today's world and being in your situation. And without knowing anything, I could have just as easily inhaled as much THC as you did, and with who knows what the results would have been, but it wouldn't have been good at all. And so I have great empathy for you, but I also I want to make this comment that they are not educating the users either. So Chad knew that it could cause psychosis because of what happened with his roommate. But I don't think Chad had any idea that it could be deadly, or that it could lead to violence. And I think that this is the fault of the industry, the fault of our government and the public health organizations who quash this information. But on YouTube, you can find plenty of videos of an experienced user getting a naive user too stoned, and it's funny. They make a joke out of the psychotic reaction, out of the vomiting, out of the stuff that you see in emergency rooms. The YouTuber thinks it's funny, and they get hundreds and thousands of views. So apparently other people do too. And this is, it's so damaging to our society that they accept the harms of marijuana as funny.
It's appalling. And I'll say as a clinician that is the topic of today has been absolutely real and occurring. And even Bryn's situation is not the only case. There's many other cases around the country that have had a similar tragic outcome. But the other thing is there's physiologic effects, changes in blood pressure, changes in heart rate, seizure activity, a condition we refer to as intractable nausea and vomiting. We use cannabis, we use THC in chemotherapy patients because of its ability to help regulate the nausea and vomiting center of the brain at specific doses and concentrations. What we're seeing now is, in addition to the psychiatric effects, many patients coming in with these physiologic effects and having severe adverse side effects that are not just psychiatric. Intractable nausea and vomiting is when the brain's center that controls vomiting gets rewired and they can't stop. So these are people who come into an emergency room and may spend days to weeks waiting for that to re-regulate itself. And they're having to receive round-the-clock IVs, specialty anti-nausea medications. It's destructive to an individual's gastrointestinal tract. They can't keep fluid or water in. So there are many other side effects that concern clinicians equally. And like I said, Bryn's situation is not isolated to one. It's unfortunately happened many other times.
Dr. Buffington, what would you say to people that try to compare this case to like vehicle manslaughter, or, well, then the bartender should be blamed, or things like that? Like, how would you compare that to my case in similar differences that people think it should have been the same as like vehicle manslaughter?
So the majority of that discussion comes down to a scenario where did the person, and if we're going to use this as a cross analogy, did the person that drank to excess and someone gave them the alcohol and watched them drink to excess, get behind the wheel and cause harm? This was very much a central part of the case, is that necessitates that the person was aware that could be the outcome and chose to do it through it to that point and had that outcome. That was not the case of the facts of this case at all. This was something you were naive to, had only experienced or been exposed to a few times, to my recollection. And this was something you had no idea what was going in that pipe. You didn't prepare. You didn't say, this is what I know I can drink and handle. I'll take this much in this form under this name of a beverage. This was something prepared for, and I'll use the term commandeered by someone else. I can't and don't know his intent, whether it was to laugh at you or something else. I don't know. We're not going to know. But in this case, you didn't set out to become impaired. You didn't set out knowing that it could impair you to that degree. And you didn't touch or prepare the items. Someone else did, and someone else who had the knowledge. So there's a whole separate issue in alcohol law called dram shop, and that's a type of law with very specific criteria. This didn't coincide or cross paths with that by any means.
Thank you for explaining that, because it has been a very common comment that a lot of the public are saying and, voicing their opinions about in terms of comparison to something that the public kind of knows about in terms of drinking and driving, but we don't know much about what we're
I would
talking
say what
about.
makes that even more preposterous for someone to say is the very fact that we're having this discussion and the fact that most people in society don't know that that's even a potential outcome simply underscores the same original statement, nor did you.
Right.
So no, this wasn't something you put yourself in jeopardy. Did you accept to do the hit? Yes. Did you have any perception or pre-knowledge that this could be an outcome? And the answer is none at all.
Correct, and that's very correct. Yes. Mhm.
So this is something, that I also talk about a lot, is that this is the fault of the industry and our government for not putting the equivalent of don't drink and drive signs out for marijuana. Marijuana can make you not only intoxicated, but psychotic, and it can cause violence. We need basic health billboards like that.
I get a lot of questions from law enforcement, from the courts, regarding some of those kind of things. And I can tell you it is almost universal that people think because marijuana is, quote, legalized, whether that's medical or recreational, that means they can do it, use it, whatever they want, and it's legal.
Mhm.
Totally missing. So now, Heidi, back to your point, missing the understanding that it is, even though it has become medical or recreational, it is an impairing substance. And you can't just use it and get behind the wheel. You can't just use it. So it is a misperception frequently every day in the courts by people who say, but it's legal. Why am I in trouble? It's because you got impaired in the process for driving. In fact, I just heard a statistic last week that states who have recreational have increased rates of DUI. So it's what was predicted. It's just a matter of educating the public to treat it just like alcohol, in that it can impair your driving skills.
But not just driving, but that it's, when we talk about the psychotic reaction that a person can have, on one use. Now, I mean, I think you described that that there are some people who have heavy intake of alcohol and that they can die. But how often can they have psychosis? And when we compare it to, say, marijuana, I mean, it's further down the line, I think, people who have chronic alcoholism, that they can have a psychotic reaction. Am I correct?
But just to clarify, you can have a psychotic reaction even if you're not a chronic drinker. It's from the amount you drank.
Okay. Okay. Thank you for clarifying that.
Dr. Buffington, how have people responded to you when they listen to your scientific explanation of things with marijuana, psychosis, and such stories you've experienced or heard of? Are there people that still deny your expertise, basically, or are people kind of understanding like, wow, this is actually becoming a thing?
I think the science and the numbers speak for themselves. And at times I feel like I'm just delivering based on hours and years and time put into researching the topic and finding the examples. But I think one of the problems we've made as a country, so it plays into my answer, blends into a larger concern that I have, and that is that the perception of it should be okay based on what people knew it was in the past, a lighter, milder type of experience, and the perception of its revenue generating ability. So what I'm talking about now is legislators and businesses. Heidi, like you said, the commercialization around this. And Bryn, to your answer, what I see frequently as a starting reaction to this discussion is what I refer to as anecdotal stories. So in healthcare, we don't approve medications on anecdotal stories. I will say anecdotal stories are the driver for clinical research. Remember I said in 1985, we had medical marijuana under multiple products. And we've been using it throughout my entire career. So it's not new, but the message got morphed. How did we get those medical marijuana products? We got them through good clinical science, well-structured studies, FDA review and approval, the same way we convert any new substance into medical use and an assurance of safety and outcomes or efficacy. What we did, though, is we let this sense of commercialization and anecdotal stories around marijuana accelerate like a wildfire a reception to, well, let's go ahead and deal with this issue and let's get it approved. What did we jump over? I can tell you in the last 15, 20, and 30 years, even after those other products were approved, by the way, they're still in use today. They're great products. There is no question that THC, the active ingredient, the active chemical, has medicinal purposes. It does. But it needs, like anything else, needs to be used properly and safely. With that being said, we jumped over years of research and just in those early states that adopted, driven by resources and investment from Canada and China, that's been well documented as well. We jumped over the necessity or the expectation for clinical research and safety studies and jumped right into medical marijuana with a hall pass and commercialization for recreational. So there is reckoning to be paid for this societally. It's not a conspiracy theory. It's studying what's happened over the last 30 to 50 years. The reckoning is that as higher potency and medical marijuana commercially available and recreational is made available, there will be a persistent chase to develop higher potency and faster delivery vehicles to ensure that people can get the high that they're chasing. In other words, we don't need those high concentrations for medical uses. In fact, like in any medication, fentanyl is a prescription medication that is amazing for pain. We use it every day in the right circumstances. And those products that you'll get access to through medical pathways to treat real conditions will have limitations on the size and the amount you should take per day. Why? Safety. That's what we're jumping over. We're jumping over the time to do. In other words, I would have been very happy at a federal level and even an international level of saying 10, 20 years of aggressive, good quality clinical research initiatives. Because we already know THC has medicinal purposes, and there may be, out of those 500 chemicals, 20 others that find out to be some of the next great medicinal therapies. All real potential. That's how the pharmaceutical development industry works. And I think we've jumped over that. So what we're seeing and what we're going to see is more side effects, toxicity, and an awakening and an awareness. So Bryn, to your point again, a lot of anecdotal stories out of emotion got this pushed into general use. And it's just, we still see individuals with alcohol going into rehab. And it's been around for, so it just like alcohol, if people want to compare it, there will be effects and there will be consequences and problems to society as a result of it for too much exposure and too lack of commitment to clinical research before it became that relevant or available.
Those are such good points, Dr. Buffington. And I wanted to ask you too, this new industrialized grade marijuana, high potency marijuana THC that we're talking about. Do you think if we would have legalized old school hippie weed at the 1%, 2%, 3% and just like stop there instead of producing all these really concentrated powerful products on the market, do you think we would have as many consequences?
Oh, and what you're really saying comes down to a very basic clinical pharmacology term that we use, and it's called dose dependent. And a substance can have an effect, but its response, the magnitude, the risk of adverse complications are dose dependent. That as that dose goes higher and higher, we find a ceiling to where there was some effect, but now it's into risk and complications. And that's exactly, you might have worded the question one way, but that's exactly the issue is at 3 and 5% and moderate exposure, it's not the type of substantial risk. Now, Heidi, you brought up, you could still have side effects at that point, but the risk is substantially increased with the higher potency and the higher dose exposure.
Also, Dr. Buffington, you mentioned too that there's other cases that you possibly might be involved with, and I know you probably can't disclose that, but it is of your opinion that this high concentrated marijuana that is such more accessible to the average person nowadays is contributing to the increase in violence in our country?
Yes. And a lot of people think THC is associated with a decrease, like a calming and relaxing effect. But again, when you go to the higher potency effect and that increased dopamine and glutamate release effect, it's you end up with psychotic reactions. And at that juncture, normal judgment isn't being applied, and violence and aggression are part of that spectrum.
Is Bryn Spejcher's case the first case you've been involved with that were 100% cannabis-induced psychosis, or has there been other cases you have been involved with?
No, numerous over the years. This obviously has a tragic outcome, and some of the others have as well. And there's multiple other cases in the media right now where that's the case. And actually, to kind of broaden that picture a little, when we look at, and the government is clearly aware of this, but just as we talked about the kind of modification or evolution of a species, there's also other cannabinoid. So remember, we talked about over 500 chemicals in the plant. There's been a lot of research in the last 50 years with slight modified chemical structure changes to the cannabinoid base. And we refer to those as synthetic cannabinoids. And the reason many of those never made it to the market, sadly found their way into the hands of people that can mass produce them, was because of extremely exaggerated effects. I mean, there's cases of cannibalism, there's cases of other, deaths involved and bizarre behavior. So the cannabinoids as a class are associated with that. The synthetics, probably even a higher rate of violence with them. But again, it's what I think we're experiencing and going to continue to see more of is the higher potency is driving more extreme psychiatric reactions.
Is there a difference with how much marijuana leaves you pack in a bowl in terms of the effects, the outcome effects?
Yes, and that's exactly what we're referring to. The same amount of leaves by weight, the same amount by size that you're going to say, I'm going to push into that bowl. If one of those plants is producing 85% of the plant material is THC, and the other bowl, same weight, same amount of visible material, is only 5 or 10% THC, the one that's 85% is substantially more THC. It looks, again, it looks like the same amount of marijuana, because we refer to marijuana as the plant. But the amount of THC was drastically different in the two same weights and appearance. And that is what the term potency is about. Is the fact that in the same weight, same volume, you've got substantially more of that chemical making up that.
Thank you. And I think that's why when I explained at trial, when I visually saw Chad put the same amount of leaves in the bowl, you don't, as a naive user, I didn't think anything of it. And I've taken multiple hits with other friends from a joint or some whatever it was, that to me, I'm like, oh, what would a second hit do? It's just like a normal dose, like the first one. And especially if I visually saw everything happen again the same way, just from even just previous minimal experience I had, I didn't think anything of it. Other than the only difference was the chamber, where it was visually more opaque, like you said. But again, I, as a naive user, I didn't know what that was. I didn't know what that meant. It wasn't described to me. I didn't ask. And unfortunately, I still inhaled it. And we obviously know what the outcome was. But just from packing the bowl, you'd think anybody would say, oh, it's just another same amount, you know.
And just to complicate things even more, somebody can take a medium level potency plant material, chopped up, ready to put in the bowl, and add to it drops of concentrate. So the plant was medium level potency, and the concentrate is taking it substantially higher. So there are just so many variations now of how people are purchasing, what they have at their disposal to mix. I just continue to personally struggle with knowing that on the purchase receipts and the website that he was purchasing from at that time, is that the warnings, even the people selling the product to people like Chad, were producing warnings to warn against giving it to someone who was naive.
And it was 31.8% THC was the last known product that he
That he
purchased.
Right.
But if he used the product that was found at the condo, it was NMS Labs. Is that correct? Did I get that?
No, NMS Labs was the commercial laboratory who did the testing on various substances. So, blood samples, other things, raw material samples. NMS is a commercial lab we use routinely too, that does forensic testing. So they weren't a producer of the marijuana.
Oh, no, not the producer, but what they found on site, they tested and they determined it was somewhere between 12 and 16% THC. And
Right.
then,
You can't test for what was in the bowl because it's already been burned.
right. So, but the leftover product, if he had stacked something between 12 and 16%, that's a potent dose itself.
No question.
Yeah.
When Dr. Chris Mahandi testified, he was the clinical psychologist that was for the state of California. And he, in his testimony, also said, all the good stuff could have been gone in terms of all the, I'm assuming, marijuana leaves were burnt up or used up. And so it wasn't the possibility that all the good stuff was gone or inhaled, that we might not know actually how much THC might have been tested, or there may be that theory. Am I saying that correctly?
Correct. Plus the fact that, as you saw in those purchase patterns, that's what he typically bought and had at his disposal, was the higher potency. And again, he was known for using high potencies and mixing with other types of medications or substances routinely. So his response would not be expected to be the same as her response.
I have another question. On the slide where you talked about the different variables that contributed to the kind of the perfect storm for Bryn to experience a cannabis-induced psychosis event, you didn't necessarily have age on there. And we've been told, like, the main message is that these products aren't safe for young people, adolescents under the age of 21. But Bryn was obviously 27, is that right, Bryn? Is there any science to prove what is a safe amount for an adult to use?
No. I mean, you'll find anecdotal studies and just, individual articles about that, but we see adverse reactions in seniors, people who are middle-aged, people who are teens and 20s. So it's, you know, you can get into the discussion, and I've had too many cases clinically on consults as well as in testimony, looking at the underdeveloped brain. So realizing that brain development doesn't typically finish till the early to mid 20s. That being said, some substances react very differently in, you know, children under 10 or under 15. But even that's pretty much a soft part of the science. The bigger concern with early adolescent exposure is the potential to cause changes to brain cell development, as opposed to, do they have a substantially different reaction?
One of the things, Dr. Buffington, that myself and many co-advocates that I work with advocate for is toxicology reports and every act of violence, including car crashes, and that the toxicology reports be made public as soon as possible, and everything that's in their system be listed so that everyone is aware of, you know, some drugs can be harmful when they don't think that they are. How feasible does that sound to you? How quickly could a toxicology report come out and be made public?
Right. So it's a very good question. You're in the world that I live in by saying, you know, those could be important variables in trying to understand things. The laboratory reports should be collected routinely, the laboratory samples. The testing turnaround time never takes as long as you hear in the media, where there's been a death or there's been some tragic case, and you just hear repetitively weeks and months on end, we're waiting for the toxicology report to come in. I can assure you that most of those we're waiting to talk about the toxicology reports that came in. There's a lot of consternation at medical examiners and law enforcement levels over those. It does necessitate an educated understanding of what the concentrations of each drug are, of drug metabolism. So the mere presence of something may or may not be. So it requires an understanding, but the best way we get there is through the larger and larger data set we have to compare against actual cases. So I completely agree that it should be routine, and they're likely going to be available within 14 days of being submitted. Shouldn't take much longer. A lab could get slightly delayed, but not substantially. And I think that I'm somewhat amused when I hear months go by and you still hear we're waiting for. It does not take that long to get those types of tests back. So they're readily available. We even have specialty tests. So one of the sad parts is that when a sample of blood is sent and they say run a drug screen, the average person may think that meant run a drug screen. It's what I meant. There's confusion there. It's going to run the standard panel of common things, not the everything, because it's less expensive, quicker turnaround time. And it's going to catch the common things. But very frequently, that's where those synthetic drugs come in. That's where other substances beyond just illicit trafficked substances come in. There's many times we need to know about prescription medication levels as well. So we have to oftentimes help to make sure that the right tests, the broad range of tests, and then the interpretation of those results have been done in a balanced and accurate fashion. There's also differences between post-mortem, after death, blood levels and concentrations, and trying to compare those against ante-mortem or pre-death. The values are not always the same, and there's reasons that we can explain why. So just looking at a number in an autopsy should never just be reacted or knee-jerk reacted to. It should be thought through and understood about what we can tell about the individual.
Is the blood a good medium to test THC in, since it's a fat supplement?
It is the ideal medium.
Okay.
So this could be a whole separate presentation.
Yeah.
Urine, hair, nails, sweat are all vague indicators with oftentimes no way to tie back to what a concentration or a level was. They serve their purpose as very basic tests, usually to say, is there something sort of there that we could confirm with a blood test for someone who shouldn't have anything there? So abstinence, they help with that. But only blood gives us the granularity, the detail, the relevant information about what's in your system and the concentration.
Thank you, Dr. Buffington. I appreciate you joining in on this podcast and taking the time to do that. You have been very educational about so many things since I've met you and just at trial alone. And I really hope that this information continues to spread and people learn more about the dangers of marijuana and what can happen. And, you can only do so much, but I appreciate you being here. So thank you.
Pleasure to be here. All right. Glad to help anytime.
Thank you so much.
You guys are doing great things.
Thank you.
Thank you.
The Every Brain Matters community is a trusted educational resource driven by science and lived experience. Every Brain Matters is a nonprofit community developed by families negatively impacted by industrialized marijuana. Visit everybrainmatters.org. Join us. We're finding freedom from marijuana and the drug crisis.